Hello and welcome to today's Connect and Learn webinar. Today's webinar is SafeScript, real-time prescription monitoring in Victoria and how it will impact our clients in the alcohol and other drug sectors. Before we begin the webinar, I would like to acknowledge the traditional custodians of the land where we're recording this webinar today, the Wurundjeri people of the Kulin Nation. I'd like to pay respect to elders past, present and emerging, and also pay respect to any Aboriginal people watching us live today or watching the replay of this webinar. So we like to make these webinars as interactive as possible, and we have a new screen that you'll be able to see while you're viewing today that has a couple of icons that will interest you, and we invite you to place comments and any of your questions into the chat box at any time. The chat box on this screen looks like a hand inside a dark blue circle. So if you have a look at that now and click on it, you'll see that you'll be able to type in any comments or any feedback that you want to give to the presenters today. And that's also where you can put your questions at any time during this webinar. And part of my role is to present the questions to the speakers today. We also have a download of the slides that you'll be seeing in this presentation today as well, and you'll be able to find that in the light blue circle that sits underneath the dark blue circled hand. So you can go ahead and download the PDF of the slides that you'll be viewing today at any point, and do make sure to pop in some questions or some feedback or comments along the way as well. So just to let you know that the Connect and Learn webinars are funded by the Department of Health and Human Services and hosted by Turning Point. So there's 10 of these webinars across a year, and they are geared towards delivering education, training and information to AOD clinicians throughout metropolitan and regional Victoria. So my name is Sheridan and I'll be the facilitator of this webinar today. So I'd like to go ahead and introduce our speakers today. So we're very lucky to have two experts co-presenting today. Melissa Bogue is from... Hello, thank you so much, Melissa. So Melissa is the Manager Change Management for SafeScript. So welcome, Melissa, thanks so much. And we also have Laura Bajerney, the Information Officer and the spokesperson at the Alcohol and Drug Foundation. So I'd like to say welcome to both you, Melissa and Laura. Thank you so much for sharing your time and your expertise with us today. And so I will hand over to both of you now. Thanks so much.
Thank you. Thank you for the introduction. So this is just a brief summary of what we're going to run over in the presentation today, starting with the rationale behind why we need SafeScript, what SafeScript looks like in practice, how the implementation is progressing, and then covering off on some common concerns and myths with time for questions at the end. I did want to start by making a quick note about language. The Alcohol and Drug Foundation follow some guidance from a couple of peak organizations to focus on person-centered language. So that's to say things like a person who uses drugs, a person experiencing drug dependence, as well as non-prescribed use and substance use. So although misuse is a common term in a lot of data collection reports, we won't be using language like that in this presentation today. So in terms of why SafeScript, look, really to set the scene, we're recognizing that harms from the use of pharmaceutical medicines is a significant and a growing public health issue. The media attention can often be on illicit drugs, but we're seeing significantly more overdose deaths from pharmaceutical drugs than from illicit drug use. So in 2017, at the top there, you can say that prescription drugs are responsible for 414 deaths in Victoria, with illegal drugs responsible for 271. And when you look at the overdose death data, in 2016, we say that in 87% of those deaths, it involved the prescription drugs, a drug class benzodiazepines, and 62% involved pharmaceutical opioids. So that's not to say that those drugs were exclusively responsible for the deaths, but they were contributing factors to those deaths. At the top of this slide, you can see a comparison in Victorian deaths with prescription medicines across the top, then illicit drugs, and then the road toll at the bottom from 2011 to 2017. Generally speaking, we've been doing okay with the road toll, less so with prescription medications. So from 2012 deaths from prescription medication overdoses have outstripped our road toll in Victoria. The graph just below describes just one of the drugs that's captured by SafeScript, which is oxycodone. You can see in the early 2000s, the blue line starts, and that's the levels of prescribing, and that steady increase up until 2014 on the right-hand side. And in red, we have deaths from oxycodone there. So you can see a direct correlation between the level of prescribing and the level of deaths related to that drug. And I did also want to make the note that that only captures death. That is not the only harm that's associated with oxycodone use. Obviously, it's a really serious one, but it's certainly not the only harm coming from that drug. And that is only one of the drugs that's captured by SafeScript. Just to give a little bit more depth to this picture as well, I wanted to repeat some of the statistics that Jeremy Dwyer has previously shared, actually in a Turning Point presentation, where they looked at the between 2011 and 2013, the 838 people who died from pharmaceutical overdoses. From those deaths, 607, they were able to determine at least all or some of the likely sources of those drugs. And so from those 607, 417 of the deceased only had a single prescriber and a single dispenser. 147 had more than two, and then there was 43 that were unknown. But the point of looking at this is to say the overdose deaths are not just because people are accessing multiple prescribers to get their needs met. It's also people who are seeing a single prescriber. And look, that's part of why it's so important that we have SafeScript, because the more information a medical practitioner has, the safer clinical decision they can make for their clients. So prescription monitoring overall, there's a lot of different systems internationally. There's been a system in Tasmania since 2009. Usually the systems differ, different kinds of software, different drugs are captured. There's differences in how much has to be manually input and how regularly it's updated. So SafeScript is a style of prescription drug monitoring. We call it real-time because it happens in real time. And as Melissa will explain a little bit later in the program, it actually integrates really well with how doctors and pharmacists are already prescribing and doesn't require independent data entry. The real purpose of SafeScript is about improving prescribing practices and patient safety. The more information medical practitioners have, it means that they can make the safest decisions possible for their patients. And that includes identifying patients who are at risk of different kinds of harm, including dependence, including overdose. Again, Melissa will go into detail on that a little bit later in the presentation. So while we also expect that it will reduce the supply of pharmaceuticals for diversion, the real purpose of SafeScript is about safety. It's about improving clinical practice with a big emphasis on the safety of people who are being prescribed these drugs. So I'm going to turn it over to Melissa.
Thank you, Laura. Thank you for that terrific introduction and setting the scene of why we've implemented this system in the first place. So I'm going to just take you through what SafeScript is and a bit of information about how it operates in practice. And I fully appreciate there might be people out there who are already fairly knowledgeable about this, but just so people understand what we're talking about and how clinicians interact with it. I thought it'd be good just to set the scene a little bit. So this diagram here shows the system, how the system works in very sort of simple terms. So essentially SafeScript is an IT system and it provides information on whether a high-risk medicine has been supplied to a patient. However, and I think Laura's talked about this, touched on this, the SafeScript project is actually a lot more than just the system, and the overall intention is about patient safety. So there's more that we have implemented than just an IT system, but at the core of it, that's what we're talking about. We called it SafeScript because, as Laura highlighted, the main purpose of it is safety. It is, it's not intended to be a sort of a government monitoring or punitive measure. It's about keeping people safe. So just to quickly take you through this diagram. So as I said, it's a very complex program, but at the sort of simple level, a patient will go to a prescriber, so that could be a GP, a specialist, or a nurse practitioner, and potentially be prescribed a high-risk medicine, and Laura will talk a bit further about what those medicines are shortly. The doctor or the prescriber checks the system, and assuming everything's okay, the prescriber then issues a prescription. The patient then takes that prescription to a pharmacist. Again, the pharmacist checks the system, and assuming everything is okay, they dispense the prescription. You'll notice there's a line that's to the system. So basically, pharmacists must provide data to the system so that when the prescription is supplied, the prescription actually goes into the system. There's no data entry required. The data is collected through something called a prescription exchange service, so it all happens automatically. There is a dotted line for the prescriber, because while it's not mandatory to supply the data from a prescription side of things, noting that some doctors don't use prescribing software, some of that data will go into the system as well. And so I'm just going to explain a little bit about how the system actually looks to clinicians using the system. So the experience that clinicians will have will be a little bit different depending on the type of prescribing or dispensing software they're using, or if they have access to software in the first place, and not everyone does. As I just mentioned, that a lot of prescribers still like to handwrite prescriptions. But assuming that the software provider has offered integration with SafeScript, and a lot of them have already, the prescriber and the pharmacist will get a little pop-up.
Okay.
We'll get a pop-up to say, this is these are the records in the system, and really this is just to basically decide whether it is, it's to basically streamline workflow. That's quite different to, you'll hear people talking about alerts. That is actually what you see. If you click on the notification, it takes you through to the system, and then the system will tell you if there's any high-risk circumstances. So the system doesn't actually red flag patients, it's just about the circumstances. And as you can see from this slide, the three main things that could potentially be unsafe is that there's multiple providers. So if the patient's visited more than 4 prescribers or pharmacists in 90 days, if the opioid dose is very high, so 100 morphine equivalents is considered quite a dangerous dose, or if there have been high-risk combinations of drugs. So often when people overdose, it's not just about the medicine, it's about the combination of medicines. It doesn't prevent the clinician from prescribing or dispensing. It really is intended as a respectful starting point for a conversation with the patient, and it doesn't mean that there's anything wrong or the patient has done anything wrong. It's just about giving the clinician good information to make a better clinical decision. So I'll just pass back to Laura, who's going to take you through the drugs that have been monitored through the system. I say through the system because the system itself doesn't actually monitor anything. This gives the clinicians information to monitor the risks associated with the medicines.
Yeah, and the process that was conducted to determine which medicines would be in scope was quite comprehensive. So the DHHS actually engaged Austin Health to conduct a literature review. Anyone who's curious about the rationale for the inclusion or exclusion of certain medicines, that literature review is available on the SafeScript website. It's very detailed. They do a really excellent job of going through all of the pros and cons. They specifically focused on Schedule 4, so prescription-only medications, and why some would be included or excluded. So following the literature review, it was then sent to an expert advisory group, and that had representation from medical, pharmacy, and consumer groups as well, who considered the literature review and then put forth the recommendations for inclusion. And then that was open to public consultation afterwards. And actually, as a result of the public consultation, codeine was added to the medicines in scope. So you can see here, this is the first classification of drugs that are included. It's all of the opioid painkillers. This is important to capture because of that opioid threshold dose that will come up as an alert, because we know that at certain thresholds, people become significantly more likely to experience an overdose. So it's really important that clinicians know overall what the level of dose that's being prescribed to a patient. And it's all of most of your usual suspects, a couple of things that you might only regularly see in hospital, but really nice and comprehensive. The second class are benzodiazepines that are typically prescribed for things like anxiety and insomnia. Some of them are Schedule 4. I know alprazolam was scheduled up to 8 in 2014, I think. But again, the rationale for including all of the benzodiazepines is really well explained in that Austin Health literature review in far more detail than I could go into now. So I would encourage you to have a look for anyone who's curious or who has questions about that. And then there are a couple of they've included the Z drugs and the sleeping tablets, which again, they're Schedule 4, but they were perceived to have a sufficient level of risk for harm to be included. The stimulants for ADHD and narcolepsy, and a couple of other high-risk medicines. We've got a stray antipsychotic up there, quetiapine, which again in the Austin Health Lit Review, they lay out the evidence that they have suggesting that quetiapine, more so than other antipsychotics, does pose a risk for harm and does belong in the system to be monitored. So back to Melissa to talk a little bit more about SafeScript in practice.
So we'll probably go into some of these points a little bit more in detail later on, but just things to note that patients, unlike other systems that might be out there, patients can't actually opt out on whether they want their records to go into SafeScript for obvious reasons. It's also not possible for prescribers to hide records in the system. They can choose whether their prescriptions whether they connect to a prescription exchange service, but if their prescriptions are filled, the records will always go in at the pharmacy level. And really importantly, we have quite tightly restricted the access to the system, noting that this is quite sensitive information. Only clinicians that are directly involved in patient care can legally access the system. There's some controls around that, which I'll explain a bit further later on, and there are penalties that apply. And another important note, at the moment, SafeScript is an optional tool to use, but it will become mandatory from April next year, and this means that eligible clinicians will be required to make reasonable steps to check the system every time they prescribe or dispense a medicine in scope. There'll be some exceptions to this, and these are usually situations where the supply of the medication is happening in a sort of a contained environment. So basically, if the patient is in prison or police jail, if they're resident in an aged care facility, and if they're an inpatient in a hospital and the prescription's been, the medicine has been administered to them as opposed to prescribed to take home, then they won't be required to check the system. However, in an outpatient setting, or if they've been prescribed something on discharge, then it will be mandatory to check the system. And also, if someone's in palliative care, obviously we wouldn't want to create any sort of barrier to accessing treatment. It wouldn't be a requirement to check the system. However, it should be noted that it doesn't mean that people can't use the system if they think that there's something they'd like to look at. And the system is available in all settings, regardless of whether they have prescribing or dispensing software. So it's available through a web portal, it's available on tablet, and I can announce that it's actually available on mobile phones, I think, from this week. So that's pretty exciting. And I'll hand back to Laura, who will talk about some of the other things that are in place to support people in using the system and also, most importantly, the consumers.
Yeah, so as Melissa mentioned, SafeScript is more than just the IT system. Ultimately, SafeScript is a tool. It's a tool that's going to provide as much information to medical practitioners as possible so that they can make the safest clinical decisions that they can. But those clinical decisions are still theirs. So really, the tool provides the information, but it's still always going to be up to that practitioner to decide how they act on that information. So there's been a lot of support. The DHHS has rolled out a suite of workforce and consumer supports to accompany the system, and I would argue that these are just as, if not more important, than the IT system itself. So this does include online and in-person training. The in-person training has wrapped up for now, although there are some webinars that are available for people who missed out, but we anticipate there will be more opportunities for in-person training in the lead up to SafeScript becoming mandatory in April 2020. The online training is currently available for anyone to access. So if anyone viewing today was interested in seeing what the 3 online modules are, you can enroll, you can go through them yourself. The first one focuses on how to use the system. So when do you use it? How do you use it? What does it look like? The second focuses on prescribing high-risk medications, best practice prescribing, working out treatment plans, and planning for patient consultations. And the third module really focuses on respectful conversations, on patient care. It touches on stigmatizing language. So that third module has been a really good opportunity to reach medical practitioners and talk to them about the importance of empowering their patients to be active in their own health care, talking about shared decision making, talking about destigmatizing language, so that there's really the focus on improving both clinical and counseling skills. So in addition to that training that's been provided, there are also peer-based supports available through GP clinical advisors to help people manage patients that have complex needs. So the GP clinical advisors have additional specialized training in things like chronic pain management, dependence, comorbidity issues with mental health. So they exist for GPs to get in touch with and, discuss how to have those conversations, have some peer support if they have a client that maybe they're not sure how to handle and they just need some additional support. And there will be 11, I believe, GP clinical
There are
advisors.
11 already available across Victoria, and their profiles are available on the DACA's website. Just a little plug for Turning Point. It's actually the same telephone number as DACA's.
Okay.
In terms of supporting consumers, the DHHS has taken a couple of steps. One is to establish the pharmaceutical helpline. So this is a helpline that is already up and running as of last September, and it is staffed by nurses who have some specialized training in the medications so they can provide that really robust advice to callers. It is a free and confidential line. The nurses staff it from 9 until 5, and then after that it redirects to Direct Line, which of course is staffed 24 hours a day. There's also been expanded support for the organization Reconnection, which has been, working for 20 some odd years, specializing in supporting people around benzodiazepine use, anxiety and insomnia. So they do their own telephone counseling, and also, I think really importantly, they'll work with patients and their doctor to develop a management plan to work towards deprescribing. So they'll actually liaise with both the patient and the doctor to help them, both work out a plan that's going to suit everyone. There's also the public awareness campaign that you might have seen on television or some of the radio ads. It's one of the pictures on the side of the screen there. They have the big pills that are intended to communicate that pharmaceutical medicines can be helpful, they can be supportive, but they can also be dangerous as well. I know SafeScript has been doing some community education on the ground also, and a number of posters and brochures have been sent out to all kinds of different, pharmacies and medical offices. So that information will be there to keep consumers informed of what's happening. And back to Melissa to talk about how the implementation has gone.
Yeah, so I'm probably not going to go through this slide in detail, other than to say it's been a long journey. We actually have been working on developing this project for quite a long time, and we effectively started collecting data for the system from July 2018, and then we went live in a study area in Western Victoria from October last year, and then we looked at what happened in that study area to see if there was anything that needed tweaking before going statewide from April this year, so April 2019. So the little ticks down the side, all the things that the major milestones for the project that we've managed to achieve, so we're quite proud of that. And the next big sort of step in the project is when mandatory use will be introduced next year. So a few sort of key things we've found in particularly the first month since we've gone statewide, is that we have had some pretty exciting uptake of the system, even though we're 2 months in now. We've had over 11,500 clinicians register to use the system, so that works out as approximately 1 in 3 of people who are able to practice, upper registered clinicians who are actually practicing. It's a little bit of a difficult one to pin down because not everyone who's registered is actually practicing. And we've had a really great response from people using the system on the ground. It's pretty much given them a lot of opportunities to have a kind of a non-judgmental conversation, because it's based on actual factual information rather than perceptions of what they think is happening. So it's actually been a really positive thing. And in the first month, and I sort of mentioned sort of alerts previously, so they're the things where it's either multiple prescriber, high opioid dose, or unsafe combinations. There were 27,000 high-risk circumstances, so that's quite significant. It has made potentially a huge amount of difference already. Obviously, not all of those situations, as I mentioned earlier, would require a significant intervention. It might just be something that is quite perfectly safe, but at least the clinicians are able to act from a very informed position, and it helps achieve the main purpose of the system, which is a preventative measure to stop those harms happening in the first place. And then we'll move on to some things that kind of come up quite regularly, as raised particularly by people working in the AOD sector, and so we thought we'd just go through some of those things, but there might be some more out there in the ether that people want to raise that we can respond to. I'll hand back to Laura.
Thank you. Yes, so certainly pop any additional questions or concerns into the comments, and we'll be able to get to those at the end. But the first one that we wanted to touch on was the question of stigma. We know that this is a big concern for anyone working in the AOD space, and it's actually been a major consideration of the SafeScript project. There's always that concern that people who are experiencing dependence or at risk of experiencing dependence might be stigmatized by medical practitioners, and we know that this has a range of negative flow-on effects, including people being far less willing to engage with medical treatment, even if it's unrelated to drug use, to name just one. We know that the experience of being stigmatized has a serious negative impact on a person's life. But SafeScript training is actually an opportunity to talk to clinicians about stigma. And that third training module that I mentioned earlier, as well as obviously the face-to-face training, is a chance to talk to people about using destigmatizing language, about taking a patient-centered approach, and really having those respectful conversations, including, as Melissa mentioned, I work with Melinda, as Melissa mentioned, in a way that's based on data, so not someone feeling like they're being accusatory or suspicious of a patient, but saying, hey, I'm looking at your prescribing history here, and can we have a conversation? I want to make sure that you're safe. I'm worried about your health. And the training really focuses on taking that health and harm approach as opposed to a more punitive approach or accusing someone of having some kind of a moral failing for experiencing dependence. So yeah, there's really that focus on the respectful conversations. And again, as we mentioned before, I think that peer support through the GP clinical advisors is really important, because some patients, especially ones with particularly complex needs, like chronic pain, you know, as a GP, you might need that additional support to lean on to know how to manage that particular case, and that can be things like helping with alternative and complementary therapies, for example, or even just how to start the conversation with a patient when you're worried that they might be at risk of harm. So while I think that being concerned about people being stigmatized is a valid one, it is something that's really been taken into consideration as part of the development of SafeScript, and especially as part of the training and the further support that's being provided to doctors and pharmacists. Was there anything you wanted to add on stigma, or is that?
No, I probably should mention that I think ADF is actually doing a little bit of work around stigma, developing some guidelines at the moment. So it's something that the Department of Health and Human Services has been working quite closely with ADF around. So it's a very high priority for us as a department. So the other one that comes up quite a lot is privacy, as I touched on earlier. We're very, very aware of the anxiety in the community, particularly with other health systems that the IT systems that I won't name that have maybe received a little bit of negative press around privacy, but the SafeScript project has had a very strong focus on privacy all the way through the development of the project, and we have done a privacy impact assessment and looked very closely at IT security measures, including things like encryption of data, which I won't explain in detail because that's not my area of expertise. We have made it very clear that so the legislation is quite clear that only practitioners who are directly involved in patient care are able to access the system. And there is actually a view history, so that anytime someone looks at a patient profile, that's actually recorded through the system. So if there is inappropriate access, that's something that we can pick up on, and that's quite important. Something we're quite clear is not acceptable. And we also, as I mentioned before, there are penalties for people who do choose to look up the system inappropriately. There has been quite strict processes to make sure that, so the registration process that I mentioned earlier, the clinician has to prove that they're that clinician by getting their identity verified through an ALPRA registered email address. There's also, when people are using the system, there's multifactorial identification processes, and for people who are not familiar, that's a similar sort of process that you would use when you're using, say, a bank and you're introducing a new, say, person you want to pay. You get a code to your phone and you have to verify that you're that person to set up a PIN, and they have to set a PIN every day. So there's quite a strong emphasis on privacy, and we've been quite pleased that we haven't had much resistance because people really understand how important it is. And it probably should also stress that health professionals, regardless of the system, have privacy requirements in the Records Act and also the Privacy Act that they must adhere to.
So one of the other concerns that was raised was significant worry that patients wouldn't be provided the support that they needed that it would be more a refusal to prescribe rather than a supporting a process of deprescribing. Again, it comes back to that SafeScript training where doctors are really being supported to have those respectful, well, first of all, to discuss risks, including dependence up front before a prescription is written. So I really do want to emphasize the preventative aspect of SafeScript, where it's about trying to make sure that people don't find themselves experiencing a dependence or experiencing other harms from these drugs in the first instance. So there is a real emphasis to the prescriber on having a conversation about risks and benefits, talking about the potential for dependence, and having a long-term strategy in place for eventual deprescribing. So I think that there is a good focus on making sure that patients are supported. Again, part of the training is focusing on how doctors can assist them in a process of deprescribing instead of just cutting someone off, for lack of a better word. That's really not how it's been organized in the training. Also, there's the pharmaceutical helpline, especially if someone maybe is uncomfortable having a conversation with their doctor, they can phone anonymously for free and have a conversation with the nurse about things if they're worried that maybe they are experiencing dependence or tapering down their medication. There is that option to do it anonymously as well. And as we mentioned before, reconnection is there, especially to help with benzodiazepine use. And the GP clinical advisors, again, as we mentioned before, they're really to support doctors in helping those patients, especially with complex needs. So I think that the training and support is well organized to support doctors to support their patients. And I'm going to turn back over to Melissa.
So this is probably an extension of what Laura was just saying. I cannot stress enough that SafeScript doesn't tell doctors in particular what to do. It doesn't tell them to stop prescribing. It really just gives them information to make better clinical decisions. And we've really put quite a strong focus on making sure that doctors feel actually empowered to do that, and they're able to sort of have a, rather than behaving in a judgmental way, to have just to begin with a respectful conversation. So and really what we believe is this increased transparency really does encourage best practice rather than those split-second judgmental or based on physical appearances. So that's probably all I was going to say on that, unless you had more to add to that, Laura.
No, I think you covered that quite well. Did you have any last remarks, anything that you wanted to polish off saying about SafeScript and its implementation? And
well, look, it's still early days, but we're really excited about how things are going. And it's another example of Victoria doing something really impressive ahead of perhaps other states. Just a little plug for us and state government, and hopefully we'll move towards a national system over the next in the future without committing, because obviously we need to think about the country as a whole.
And it's certainly something that a lot of organizations and individuals, including coroners, have been calling for some time. So really great to see that rolled out now. Awesome. Great. Thank you.
Thank you so much to both of you for your wisdom and your time today. So we really appreciate that. There have been some questions that have come through, so I'm just going to read those now, and maybe you could just nominate who would like to answer that. So the first question, which you've kind of touched on this, but the person is just asking, will GPs also be provided with information and training about accessing home-based or residential detox and rehabilitation services? So will they be provided that training so they know how to make those kinds of referrals?
There is a little bit of that in the face-to-face training. Unfortunately, there's a lot of content to cover. So yes, that is included, and they also have support through the GP clinical advisors who are, that service is actually run by Turning Point, and that's one of the things that they have been trained in to understand the whole sector. Unfortunately, at the moment, there is a little bit of a disconnect between primary care and the alcohol and other drug services, and that's obviously a bigger issue than just this project. And it's something that I know that in the department we're quite aware of, and as I'm sure you are, Sheridan.
Yes.
So we probably we all need to work on that sort of going forward.
Well, I know that the that third module of online training at least touches a little bit on when deprescribing could be managed in primary care, when there should be specialist involvement, and when there needs to be more coordinated care between specialists.
And I should sort of point out that it's not a very often that someone would need that sort of level of treatment. This is a preventative tool, so and it may just be that the GP or the specialist, depending on the circumstances, just needs to think about the treatment and their treatment plan, and maybe looking at different options for pain management. It's not there isn't a lot of not everyone will be dependent, not everyone will need home-based withdrawal, but yes, that connection between I think going forward we need to sort of get people to understand the full suite of services that are available.
Yeah, that is the aim, isn't it? Yeah. And then on that, we have somebody else who's asking, is it mandatory if a GP does identify that there's an issue, is it kind of mandatory then that they do make some kind of referral, or they just, or that they do?
Totally.
It's
we
still
are not.
You've already really
the
answered that,
purpose is not to tell the clinician how to do their job. They study for many, many years to learn how to be a doctor or a nurse or a pharmacist. So they're the experts in that. Well, obviously, we're offering additional training, but it's their decision on what they do with that information. We just encourage, obviously, the respect and the conversations rather than making judgments on people, which goes back to the stigma.
We've got another question, if you're happy to keep answering these. So we've got another one that says, first of all, thank you so much for an excellent presentation.
Thank you, whoever that was up there.
That's Sarah, so thank you, Sarah. So Sarah's question is, what happens if the doctor has said yes, but the pharmacist says no, especially in cases where the pharmacist is unable to get in contact with the doctor to query a prescription? Are either of you able to answer that one?
It's a great question.
Yeah, look, it's not a simple question. Obviously, it's already an issue. It's not something that's actually been an issue because of SafeScript. That would already be a problem if a pharmacy was presented with a script that they didn't think was safe. So it's the same processes that would apply as previously to SafeScript. But yes, the pharmacist has a responsibility that's what their role is, to ensure that script was safe. So that the good practice would be to go back to the doctor. In some circumstances, they might ask the patient to confirm the script with the doctor. And sometimes there are errors on scripts, so it isn't necessarily. Sometimes the pharmacist might pick up on something that is unsafe. That's completely unintentional.
Thank you. And another question, which I know I've heard before, is, where are they? Is there? There's a few of them. So another person has asked, has there been an increase in people utilising AOD services?
Look, we are actually monitoring that. Obviously, that's been a concern that people have voiced earlier on in the project. We're not seeing any evidence of any increase in intake to AOD services with people identifying a pharmaceutical as a primary drug of concern, and we're not seeing an increase in permits for pharmacotherapy at this stage in the project. However, we are mindful that we need to be keeping an eye on any kind of unintended consequences from the project, but it's not looking like that is going to be a significant way things are heading. However, I probably should point out that prescription medicines, as you know, Laura demonstrated earlier in the project, are becoming an increasing issue more broadly, and so regardless of SafeScript, we are seeing this as a bigger issue in the community, so I can't say that that won't be something that services probably should be mindful for their planning for the future, to make sure that they have the capacity and understanding of prescription medicines as part of the suite of drugs out there.
I do see that, though, as one of the strengths of implementing SafeScript now, though, is that preventative element where we've been seeing an increase in harms, including death, whereas hopefully this will assist in preventing those issues and preventing people from becoming dependent in the first instance.
So, yes, thank you for that.
Also, you mentioned before the Austin Health report.
Yes.
Yeah.
And so somebody's just saying, where can they find that?
It's on our website, so that's health.vic.gov.au/SafeScript. And you will find, or just Google SafeScript, and you will find the report on medicines and scope.
Yeah, you can just download it as a PDF. And as I mentioned, it's really comprehensive and does quite clearly lay out, the pros and cons and the rationale for inclusion or exclusion.
Beautiful. And so it isn't completely statewide yet, is that right?
It is statewide.
It is now,
it's available statewide. It's just not mandatory to use it, to register and use it just yet. So 30% is quite an impressive uptake for a non-mandatory system. It's kind of blown us away, actually, and it shows how much of a demand there is for this system out there, and clinicians are saying it's completely transforming their practice and giving them, that the tool, the information to be better clinicians, which is really what we want to see.
Beautiful. Okay. All right. We're probably going to need to leave the questions there, but just to let you know, a few people have kind of given their praise for this and said thank you so much. It's been a wonderful and informative and also an easy to understand presentation. So thank you so much for the way that you've delivered that for people today. So we will leave it there. Thank you so much for coming and presenting for us today and making it so easy for people to understand. And so if you haven't downloaded the slides, please go ahead and do that. They're there for you. So everything you've seen today as a PowerPoint is saved for you on your screen as a PDF. So you can download it and refer to it later. And I did want to let you know that we will have our next Connect and Learn webinar same time on the 12th of June, and we have Hepatitis Victoria. We have a speaker from Hepatitis Victoria coming in and delivering the Hep Ready training in a webinar format. So I know a lot of people a lot of AOD clinicians have talked about not being able to get to that training. So Stephen from Hepatitis Victoria will be delivering that as a webinar on the 12th of June. Make sure to look out and register for that one. And on our website, the Turning Point website, and also you'll see it come through VARTA e-News as well. Thank you so much for spending this time with us today, and we hope to see you at the next webinar. Thanks very much.